as we continue to talk about not only what health equity means when we talk about mental health and access, but also what are the solutions out there. Of course, the goal is that with awareness comes action. So that's part of what we're discussing today. I want to introduce our panelists now. First up, Lisa Jones Chandler, who is Vice President of Corporate Excellence at Vibrant Emotional Health and also a specialist on equity within that organization. Vibrant Emotional Health works with individuals and families providing mental health services and also focuses on advocacy work to advance access. Lisa, it's great to have you with us today. Also
Thank
joining us,
you.
Dr. Dorianne Miller, who's Professor of Medicine and Director of the Center for Community Health and Vitality at the University of Chicago. Dorianne serves the community rather in South Chicago and also works with the University of Chicago's ECHO program, which extends mental health expertise into communities in need. Great to see you again this afternoon. And also joining us, Dr. Glenn Goff, who's Senior Technical Advisor for Mental Health and Psychological Programs at AmeriCare. So Glenn oversees AmeriCare's mental health programs globally, easy for me to say. Great to have all of you with us. And I just want to remind you, if you do have any questions, we'd be happy to take them at the end of the panel. So feel free to throw those out there. As we look at where we're at, I think you each have such a unique view of what some of the barriers are to access and to health equity, specifically when we talk about the barriers to mental health services. And you each have a unique view based on the communities that you serve, the communities that you're working with. And again, we can't get to solutions without first understanding what those challenges, what those problems are. So I thought that maybe we could touch on the barriers within the communities that you serve first. And so Dorianne, I'd like to start with you. I was really struck when this panel met in advance of the summit last week, as you were talking about just the wait for someone who may need behavioral health services can be as long as 10 months. And when we all think about if your barrier to care is this long waiting period, what's to say that you're going to still want to be there in 10 months? So talk us through a little bit about what the specific challenges are to that barrier, and what you're seeing within the community.
Uh, Erica, thank you so much for the question. As I think about barriers to receiving mental health care in the community, not only is there an issue of capacity within the traditional mental health space, and that particularly for people who have serious mental illness, waits can be up to as long as 10 months in order to receive care in those settings. But there are also financial barriers as well, because many times people who have mental illness oftentimes are either uninsured or they have a public health insurance such as Medicaid, or they may be on a plan through the Affordable Care Act, and there may be limited capacity for the mental health system to take these patients in. As you mentioned before, I work on the south side of Chicago, and within the primary service area for University of Chicago Medicine, we have 6 of the 8 poorest communities within the city of Chicago that exist within our primary service area. And so thinking about how people would be supported through health insurance, as I said, many on Medicaid, many who are uninsured, along with these wait times, I think provide significant barriers to care. In addition to that, and I think it's something that Dr. Patel referred to in some of his comments, and one thing that's the theme of this conference, and that's the issue of health equity and thinking about some of the implications around both race and ethnicity. The ability to have someone that is serving you in a mental health capacity that understands the delivery of services within the context of your community, I think is very, very critical issue.
Absolutely, having a fulsome understanding, right, of where people are coming from makes such a difference. Lisa, access to services and care, I know is something that you deal with specifically as well. Give us a sense, what are some of the barriers that you're finding, especially as, I'm really struck by the work, not just with individuals, but with families as well, sort of, you're really bringing in a broader community.
Yes, thank you so much, Erica, for having me today. And I just want to say that, in addition to serving families and communities, Vibrant also is proud to administer the National Suicide Prevention Lifeline. And so it's a free confidential support line 24/7 that allows emotional support for people in distress or in crisis 24/7. And so some of the barriers we start to look at, especially in our Black, Brown, and Indigenous communities, is that we know what the barriers and disparities can look like in the healthcare system. There's a significant amount of distrust in healthcare. And so experience, unfortunately, has taught us that by having to go through this with different healthcare providers, we are not being fairly treated, even when we're advocating for our own healthcare. And so we need to really become advocates as it relates to getting or receiving medical or mental health treatment. And so part of why people access, let's say, a confidential crisis hotline is because it allows for confidentiality. It removes some of the stigma that so many people from marginalized populations tend to face. And they don't have to worry about being discriminated against or not getting their needs met, and can actually just be met where they are and get the services that they need to be okay.
I think increasingly too, the conversation around equity really does come back to meeting people where they are, which is really underscored by what you're doing. Glenn, as we look at too, Lisa just mentioned the distrust. There's also, I think, a really significant misunderstanding sometimes as to what care looks like, what it should look like, what it currently does look like, and part of that comes from what quote unquote care may have looked like in the past when it came to dealing with mental health concerns and mental health illness. So in terms of, Glenn, that barrier, this sort of knowledge gap about what mental health and mental illness really looks like and how it can be treated, I know that's one of the things that you're also focused on.
Yes, Erica. We're at AmeriCares. We have mental health and psychosocial support programming in 10 countries, including the US and including Puerto Rico. And we're expanding into 12 countries next year. Globally, the treatment gap, or the ability for people to access good quality mental health or treatment care, is 85 to 95%. But that isn't the whole story. In a country like the US, who has a large cadre of mental health professionals, there is still a treatment gap for Black, Indigenous, and people of color of 70%. One large barrier that AmeriCares is working on is stigma and discrimination of those suffering from a mental illness or in recovering from a large-scale disaster or conflict. One example would be with refugees. AmeriCares works with Venezuelan migrants who have fled into Colombia. They're subjected to human trafficking, sexual exploitation, criminality, loss of life, which often has a long-term emotional and mental health consequence. In Colombia, 19 psychologists see more than 3,000 Venezuelan migrants each month in 9 different AmeriCares clinics across the country. As you probably know, it's difficult or even impossible for refugees to access mental health or health services, but AmeriCares is bridging that gap.
In terms of bridging some of the gaps, Dorian, when we talk about getting people access to care, there's often this physical barrier. So perhaps you go, you're in a clinic perhaps, or with your primary care doctor. Some of the patients that you may see who you work with in South Chicago, they're comfortable with you in that setting, in a doctor that they see for, what they think of as maybe their physical health. But when you have to go somewhere else, right, even if you have access to that care, but you have to go to another location, I know that creates additional access issues. So how could it change things if more services were brought together, and if there was more of an ability to treat the whole person, not just the physical person, but the emotional and behavioral health as well at the same time and in the same location?
Glad that you brought up this point, Erica, because I think that it's one of the reasons why we've been very happy to partner with AmeriCares regarding the program that is called ECHO Chicago, which stands for Extensions in Community Health Outcomes. If I could just take a moment to talk about some of the work that we do in this space and why it's so important to think about ways in which we can incorporate more mental health services within the context of a primary care setting. As you mentioned before, I'm not a psychiatrist or a psychologist by training. I'm actually an internal medicine doctor, which is a doctor for adults. But throughout my career, I've seen a tremendous need for enhancing the delivery of mental health services within the primary care setting for many of the reasons that Dr. Patel mentioned in his comments, including being able to extend issues care into the community. Echo Chicago provides telementoring for community-based providers through case-based learning delivered in a setting that's actually very similar to this, high-grade video conferencing, where providers can gain not just knowledge and skills, but managing conditions, both for physical conditions as well as mental health conditions, and that they can translate this into practice with the support of their peers. At the University of Chicago, we started this program in 2010, and we were actually the first ECHO site to do this in an urban under-resourced setting. The program actually started in a rural setting through Dr. Sanjeev Arora at the University of New Mexico. And we're the longest running urban ECHO program in the world. We leverage these existing assets and we bring together AmeriCare sites, we bring together community health centers and others where there is a real gap in terms of the ability to deliver mental health services in the community. And I mentioned that 10-month barrier in my comments a little while ago, but figuring out ways in which we can bring together doctors, advanced practice nurses, social workers, psychologists in order to provide a network of care and really almost a mini system within the clinical setting where there can be warm referrals in one setting to another so that the patient essentially has one-stop shopping when he or she comes in. We also provide training. We ask for a way in which we can get a little bit of support from psychiatry, but it really does help to build the capacity, both in terms of knowledge and skills of those primary care providers from experts that are providing information, but also, and I think that this is something that's really important about the way that the ECHO program is organized. There's peer-to-peer communication around what takes place. And so it's not just me or my psychiatrist partner talking about ways in which we can do a better job of diagnosing and treating patients with mental illness, but it's also other clinics that can talk about what types of approaches they've taken in their patient population. And so it provides for a peer-to-peer learning platform. And so everybody can see one another, can hear one another. We do case presentations within the ECHO Chicago platform. And so we are able to better integrate evidence-based practice into care, and patients are able to receive state-of-the-art care in their primary medical home. For anyone who's interested in following us on social media, our Twitter handle is @ECHO_Chicago. So just a little bit of a plug for us, and I'm happy to communicate about our programming perhaps a little bit later with the conference participants.
You know, as we talk about the experience that each of you has within your communities, how you've addressed these barriers, how you're sharing that information. I can't help but think of at the very beginning of the pandemic, a number of doctors I was speaking with who were on the front lines were talking about how they'd always sort of shared best practices, but this felt unprecedented because everybody was approaching this one problem together. And what strikes me is just how important it is to bring that knowledge together that we're seeing from each of the three of you. And Lisa, when I think about the crisis lines, and you think about how this really opens up an option for so many people, how have you seen the response to that grow, and even the comfort level that some people may have in accessing care simply by picking up the phone or by sending a text?
Sure, thank you. I mean, like we've said before, right? The pandemic has really shed a light on all that we need to really pay attention to and look at in this global humanitarian crisis that we're all collectively experiencing together. And when I think about the beauty of having a crisis hotline in these instances where we were forced to huckle down and not go out, the crisis line really became an important lifeline for many people in distress. And it allowed us to reach and assess people that we could not before, or maybe people who were hesitant to reach out, who had seen our phone number across the media and were hesitant to call and get the help that they needed. And when you think about why people call a hotline, I touched on earlier about the stigma that Black, Brown, and Indigenous people and folks from other marginalized groups face. You think about the opportunity to help them in real time and also introduce them to community health workers, paint the picture for what they can look to expect when they're able to go out and get an in-person visit again. What will it look like? Many people don't know, and you don't know what you don't know, but sometimes people are too hesitant or even afraid to ask. And so calling a hotline and having that anonymous feature, or even maybe three-waying with a friend or family member when a person is in crisis, is a wonderful way to reach our community and serve people and help bring down the potential crisis and even potentially eliminate the need for a higher level of intervention.
I love the point that you made about, and I'm paraphrasing here, so I'm not going to say it nearly as well, but basically having a sense of knowing what you could expect in that care, right? And giving the patient who is looking for help, who is looking for care, a better sense of what they may be walking into. And Glenn, I wonder how much that comes into play, right? And maybe the situation in Colombia with the Venezuelan refugees is a perfect example, but helping to set the expectation, not just for what everyone, right? Everyone's right to have access to quality health care, that equity, both physical and mental health, but also, the expectations of the patients as they're coming in, and if they are in need of mental health services, setting their expectations, which also adds a comfort level for them as they're in many ways perhaps moving into uncharted territory.
Right, Erica. It is difficult for patients who are trying to access mental health services, especially globally. There are critical links such as psychotherapy by psychologists, case management by social workers, that just often does not exist. Another example, in Malawi, there's 5 psychiatrists for 16 million people, and a good comparison would be New York State, that has 5,000 mental health workers for 20 million people. So we work in that area between the physician, the psychiatrist, and the patient with almost no professional psychosocial support. And by AmeriCare is providing critical training for non-specialists that Dr. Patel mentioned, like nurses and community health workers, we can start to bridge that treatment gap. Let me give you an example also in Malawi. Recently, a 21-year-old university student in his final year came to one of our trained nurses. He was confused, hearing voices, distracted, anxious. Being an orphan and not connected to his family, he wanted to run away. But fortunately, his aunt brought him to the nurse. And using AmeriCare's training, the nurse calms him down and probes about what might be the cause of the voices and starts a therapeutic relationship with him that helped him gradually to get better. Now, of course, Erica, we would hope that there would be both medications and therapy available, but for most of the world, these strategies don't exist.
You know, when we look at where we're at, we know how COVID has impacted every aspect of our lives. I wonder, and maybe Dorian, you've seen some of this, maybe you haven't, if there have been any positives out of that, in that the conversation is perhaps coming more easily as we talk about caring for the whole person, and in recognizing that these are challenges that are being felt across the board, as we know in certain communities being felt far more than others, but still there is an impact, and certainly on emotional and mental well-being. Has that helped to open up the conversation? Have you noticed?
I think that the issues that people are facing now has helped to open up the conversation to some extent, because it's not just a question of dealing with a pandemic across the world, but also other issues as well. And I think that Dr. Patel's comments spoke to this. He talked about some of the issues around the economic stressors that people are facing. Discrimination in the workplace, discrimination in just day-to-day settings. And it's not just a question of, I primarily care for African Americans in my community, but thinking about the the violence towards Asians in our community, particularly East Asians, around the pandemic. I also think about the issue of some of the killings that have taken place within communities. I think about George Floyd, Ahmaud Arbery, Breonna Taylor, and others. I have one colleague who refers to this as a syndemic, which is the combination of pandemics coming together and having a synergistic effect in terms of how it's impacting people's lives on a day-to-day basis. Some of the things that we would normally do in order to help to comfort ourselves in terms of a sense of community, we've also been missing because we have been isolated from one another for public health reasons. And that's as simple as going to a funeral and being able to comfort one another and to grieve and to mourn together. And so many of these rituals, I think that we've missed. It's giving us opportunities to rethink how we interact with one another, but for some communities, particularly communities that may have issues around lack of access to technology, thinking about Zoom calls are not a great substitute for someone being in the same room with one another, providing that one-on-one support, that those types of things I think are missing. And so the types of alternatives and things that both Lisa spoke about as well as Glenn, doing interactions and interventions that take place throughout community members and not just within a healthcare delivery setting, I think are so important as we address these many pandemics that we're seeing in our society.
There's also a question, Lisa, of resiliency. And I think for so many people who have been disproportionately impacted by this pandemic, finding a space for that and even having that conversation can be really tough for a number of reasons that we know, and including what Dorian just laid out. I'm wondering, Lisa, what you're seeing in terms of how often resiliency, right, and the need to feel that you have some control over where you are, how that's impacting what you're hearing and what you're seeing in terms of needs.
Absolutely. I'm so glad you asked this question, right? We've talked about this theme of stigma and discrimination for certain groups in this country. And what we really don't talk about is our pull for survival and how much of it is in our DNA. And sometimes that in itself can be exhausting. We know that the support that people receive can vary and differ based on their race. And why building empathy can disrupt the impact of systemic racism is important for us all to keep in mind as health providers in this world as we support each other through this collective traumatic time. And so when we talk about stigma and discrimination, we have to also understand the impact it can have on Black and Brown Indigenous communities and how people's mental health and well-being can be affected by this. And I want to touch a little bit briefly on advocacy because as a result of that, of what we're seeing and what we've been highlighting on a national federal level, I'm not sure who are all aware, but Vibrant also has won the grant to administer a Congress and FCC designated line called 98 that will be launching next summer across the country. And it will be a universal 3-digit dialing code for the Lifeline in recognition of the need to increase accessibility of these life-saving services to everyone who needs it. And so while the nationwide availability is not slated until next summer, the Lifeline and mental health resources are available now by contacting the National Suicide Prevention Lifeline at 1-800-273-TALK. And just to highlight that 988 coming next summer is not just a telephone number for the Lifeline. It really represents a unique opportunity on how we change and deliver services for all impacted and in emotional distress. We have to keep that at the heart of this, especially with COVID in the backdrop of what we're all experiencing.
Yeah, absolutely. Keeping that focus right where it needs to be, keeping that conversation at the forefront to help reduce the stigma, to talk about the access, to let people know the resources that are out there. Glenn, as we watch all of this, the approach can be so different depending on the country where we're at, as we know, even just highlighting the number of providers who are available. I'm wondering globally what you're seeing in terms of access to mental health services in terms of equity. Is the conversation starting to change at all? And if so, where are some areas that you feel there is more progress being made?
Well, Erica, there definitely is progress being made. But, as a result of the pandemic, there was an increase of 76 million extra cases of anxiety, 53 million extra cases of depression, not to mention the large increases of burnout and stress for millions of workers, students, and family members. So that's made our job more difficult. But at AmeriCares, we are really getting back to working with large cadres of community health workers, nurses, doctors, really anyone we can, train, build capacity with the departments of health, the ministries of health in numbers of countries. And there's such a hunger for the capacity building and training that we offer. And we see with the stigma and discrimination that, just excludes and isolates people. We're really working in that area as well. A third area also is just a lack of safety and protection and human rights for those with mental illness. And Dr. Patel really spoke to this quite eloquently. But if there's no safety or guarding of human rights, people won't talk and won't be able to work toward wellness. So we had in the Philippines, for example, our rural mental health network has actually helped families to decide to have their relatives released from harsh restraints and institutionalized care in favor of community-based programs. So right across the world, we're working with the WHO, with other NGOs, our colleagues, of course, Dorian and the ECHO program that's working so well with us to help the free and charitable clinics across the United States. So we're really looking forward to countering the inequities that are there, and look forward to it.
Key to countering those inequities, I think it's changing the definition of what health is. And Dorian, when we all met ahead of the panel, you brought up the definition of health in the World Health Organization from 1946, and I was struck by how simple and how important that definition was. I'm going to put you on a spot, hoping that you have it with you, but I think it also sums up one of the reasons that we're talking specifically about equity that's partitioned between physical health and mental health is because when we say the word health in general, I think it's about your physical well-being. It's not about the whole person.
Thanks, Erica. The definition that Erica asked me to share with you is health is the complete presence of physical, mental, and social well-being, not merely the absence of disease or infirmity. And so I think that that definition is a very encompassing, holistic approach to health. And I think that many of the things that we've discussed today, and particularly in Dr. Patel's comments, are very apropos and encapsulate that statement quite well.
Yeah, it makes me think of that rights-based approach, which, I asked him to define it, and he's right. It is fairly self-explanatory, but Lisa, it's interesting. It seems that there can often be a barrier, a different barrier that goes up the minute there's a conversation about the right to healthcare, the right to access to equitable quality healthcare. Are you seeing a change at all in that conversation? Is it, for better or for worse?
Yes,
Sorry, that was for you.
absolutely. Even no, sorry, it's okay. Absolutely. At varying call centers, the crisis call counselors are experiencing this on a daily basis. People are calling in wanting to talk about how they're feeling and how they're doing and how, systemic racism and discrimination is impacting their daily lives and feeling like they have a space to be able to even talk about this out loud. There's so much we hold inside and in our bodies, and it ends up coming out in varying ways. And so our crisis counselors are reaching out to us to say, hey, people want to talk about this now. We're seeing an uptake in people wanting to share their experiences within the healthcare system and how we can do better as healthcare providers and leaders in this space by affirming and acknowledging where people are. And by taking a closer and deeper look into who benefits and who is harmed, you can then use that to give you a well-rounded approach to inform more fair treatment to ensure that everyone gets the support that they need.
Absolutely. Coming back to awareness can bring us to action, but we can't get there. We can't get to those solutions without first recognizing, admitting the challenges, the barriers, the problems that are there. Thank you all for taking the time to join us today. Thank you for the work that you are each doing individually and with your organizations to, do your best to break down some of these barriers, to break down the barrier of the stigma surrounding mental health, and to improve access to care and health equity for the whole person. It's really been a pleasure to be with you all today. Thanks so much.